Yeah. So my outline of my discussion will be which patients truly benefit most from primary prevention ICDs, how do modern heart failure therapy reduce sudden death risk, what patient-centered consideration influence ICD decision-making today, and interaction of ICDs with other newer device modalities for heart failure. Indications: anyone who is at high risk of suffering a dangerous ventricular tachyarrhythmia will require an ICD. And but the person's quality of life has to be good and has to be sure that he's going to survive more than a year. You don't need to put an ICD and then 6 months down the line you have to switch it off. Or the patient wants it. I don't know how far we can go to satisfy. But an ICD is not without potential harm. So what are the indications for ICDs? Definitely somebody has had a VF or poorly tolerated ventricular tachycardia in the absence of reversible causes. Then if there are no electrolyte imbalances, there's no drug-to-drug, harmful drug-to-drug interactions, where you cannot identify the cause, and for 48 hours post-MI, then that person requires an ICD. It can also be considered intolerated ventricular tachycardia. As for the primary prevention, patient with heart failure despite optimal medical therapy, especially ischemic heart disease, symptomatic heart failure with EF less than 35. If the EF is less than 30, we can consider those with IHD, even if they are symptomatic. And for the non-ischemic symptomatic heart failure, less than 35. But we're going to talk, because some of the trials, like the Danish trial, has really shed some bit of doubt and raised some issues and concern in the non-ischemic subgroup of people. And then we have selected high-risk patients with dilated cardiomyopathy, hypertrophic cardiomyopathy, or arrhythmogenic right ventricular cardiomyopathy, and sarcoid. And sometimes even sarcoid, probably the EF might not be that important. And with the incorporation of cardiac MRI and late gadolinium enhancement methodologies to identify the scar burden, one might consider, it's high time now we need to think of those indications where we can put other factors that may decide our indication for ICD. And of course, selected high-risk patients with primary electrical disease like CPMVT, long QT syndromes, and the Brugada syndromes. In the ESC versus ACC, the key difference is the ESC is more conservative in the non-ischemic cardiomyopathy, while the ACC, they're a bit more generous. ACC maintains stronger class 1 in non-ischemic cardiomyopathy, while the ESC, they're a bit more conservative. ESC emphasizes cardiac MRI with the late gadolinium enhancement more explicitly, and ACC emphasizes patient-centered decision-making, which is quite important, as we shall see. So future directions for ICD indications might incorporate CMR LG-based decision algorithms, genotype-driven ICD decisions, and AI-guided risk stratification. So we do know that ICDs reduce all-cause mortality across landmark device trials, and this is more so by preventing sudden cardiac death. From 1996, with the MARIT trial, 23%. All across to 2009, we have MARIT CRT, and finally, the last one being Danish, 2016, where there was modest reduction, and it was not statistically significant, raising the issues of indication for ICD in patients with non-ischemic cardiomyopathy. Now, what about GDMT, goal-directed medical therapy? Generally, from 1995 to 2019, we've had a decline in the annual rate of sudden cardiac death. And we do believe that GDMT on its own is actually antiarrhythmic, especially the more the patient is on, the higher the reduction in rate of sudden cardiac death. More so from the ACE inhibitors, angiotensin receptor blockers, beta blockers, MRAs, and now with the ARNIs on board and SGLT2 inhibitors, the rate of sudden cardiac death has gradually declined from 1995 all the way to 2018. And you can see all those trials, the Valheft, Copernicus, all the way to Emphasis and Paradigm HF. So one way is to prevent sudden cardiac death is to emphasize on GDMT, and with a strong HF trial to really incorporate them quite reasonably fast. And even now, when we look at trials of ICD, it's really, really difficult for us to really get a benefit because of GDMT, because the GDMT itself really reduces sudden cardiac death. And for trials to show benefit, probably we require larger sample sizes, or we might have to change our mode of looking at our trials so that we can be able to say their real role and who are the people, especially in primary prevention, who can be incorporated and benefit from ICD therapy. The drugs do work. We all know that. And if one was to look at the table there, all the meta-analysis, looking at the heart failure medications, one can really see, especially at the top, the fantastic four, the ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. You can see there's really, really benefit and significant reduction in all-cause mortality, especially with reference to sudden cardiac death. So you can see across there's benefit for all those medication, and it's important for us, even before we think of putting those devices to our patients, we should optimize on our GDMT and make sure that patients have been treated quite well before even putting an ICD therapy. And the trials of ICD in the pipeline are quite many, and they're using different modalities from CMR, even EP studies to identify patients who can have easily inducible VTs and VFs. Studies are looking at issues of scar burden and whether patients will be able to benefit from ICD, rather than looking at the usual indications for device implantation. So outline, I want to know that we have moved and we are moving, and we are still using transvenous ICD, but we also have subcutaneous ICD. I'll touch something about it, and extravascular ICDs. And finally, I'll also touch on ICDs in combination with other devices. So we do know that ICDs prevent sudden cardiac death, and transvenous ICDs have been used for over 20 years now, and we have a lot of experience with them. Though the complications are, but I can tell you now, the complications are becoming less and less as different things, implantation techniques are improving. Companies and pharmaceutical industries, device companies are really improving their hardwares. So transvenous ICDs have limitations, and they're associated with complication due to intravascular and intracardiac leads. We've had patients where you are forced to remove, then you realize that they've developed venous obstruction, superior vena cava syndromes. Sometimes even during extraction of those leads, it can be a bit catastrophic if you're not careful. So all that, and at one point, we see a lot of leads in the cardiac chambers. They create a lot, sometimes, issues of valvular regurgitations, perforations, and all that. So they are not without complications. And that's the reason why people are thinking other modalities and other technology that we can move to avoid all these complications. Now, if one was to look at freedom from complications from ICD and CRTD from infection, if you look at around 3 years, 3% complication of infection from ICD, but by 5 years, there's 7% risk of infection complication. And if one was to look at mechanical complication, at 3 years, almost 8% complication, and at 5 years, we are talking of almost 24% rate of complication from ICD. So we do know that those rates are quite high, and we have to think of ways to minimize this risk so that our patients can benefit maximally from implantation of these devices. Looking at pocket infection, even many years after you have removed the devices, if you look at 1 minute. How do I remove all that? Yeah, thank you very much. So mortality after extraction of infection, for infection, if you look at infection after you have extracted, even much at around 12% for pocket infection and almost 31% at 1 year for endovascular infection, endocarditis, and all that. So removing devices is still associated with mortality because of sometimes of the leads. What is the ideal ICD? It has to have excellent efficiency. It has to have painless therapy, anti-tachycardia pacing. It has to have low complication rates, smaller device. System-related complications should be less. Lead-related complications should be less. And you should have less inappropriate shocks. And we are going to pass through different types of approach for different ICDs. So from the transvenous, there's tendency to move to subcutaneous. We have not left transvenous completely, and you'll come to realize that there's no ideal approach, and sometimes you have to go back to the transvenous for the patient to benefit because somehow you could not achieve subcutaneous ICD. In the SICD trial, it offered the opportunity to avoid the complications associated with transvenous leads. So the study looked at acute VTVF sensitivity, VTVF inductions in 809 patients, and it was successful detections in 99.9%. Only one patient, there was no successful induction and detection. Conversion with 65 joules of shocks, 2 consecutive times was 100% successful. This was a small study involving 800 patients, and we could see that, yes, there is room for subcutaneous ICD. Of course, it comes with the benefits of not having leads. It's a leadless type of approach. Oh, sorry, not having leads in the heart itself. So this was followed by the SICD PASS, which was now a large real-world multi-center registry involving more than 86 US sites. Follow-up for 5 years. The efficacy endpoints was fast shock success rate and the overall appropriate shock efficacy. The safety endpoints, the system and the procedure-related complications, and any electro-related complications. So one was to look, the age, median age was around 53, plus or minus 15 years. And one thing to note about these trials, they were being done by people who are really experts in their field. And of course, it all starts like that before the technology is transferred all over. And if one was to look at clinical heart failure, 74% of them had clinical heart failure. Ejection fraction was between 32 plus or minus 15%. 26% had kidney disease, 34% had diabetes, and 41% were ischemic, and the latent cardiomyopathy was 17. Okay, and for the secondary prevention, 23%. And it involved 1,637 patients. 1.6% of the patients had to cross over to transvenous ICD, and the reason was there's room for bradycardia. As we know that the subcutaneous ICDs do not have pacing capability, and one ATP 19 had to be upgraded to CRT for one reason or another, and there was one overdrive pacing. Look at the primary and secondary. Overall shock efficacy was 98.4%. First shock delivery was 92. Complication-free rate directly related to the device was 93.4%, and complication-free rates related to the electrode was 99.3%. These are very good figures. Very minimal complication, and they do sort of give us hope that probably they might give us a solution to prevent some of those complications. And inappropriate shocks were reported at 17.1% at 5 years. That's quite high. And the reason, most of them, 85% or more, due to cardiac and non-cardiac oversensing. There's VTVF oversensing. And so this is something that we need. The companies need to come with algorithm to prevent this oversensing, because some of these devices are very close to the atrial, to the right atrium, and they could be oversensing the P wave, some of them oversensing the T wave. So these are the things that the company needs to come and deal with them by creating algorithm that will be able to take care of those oversensing. Complication, 7.3% at 1 year and 13.5% at 5 year. Infection, stroke, erosion, 3.8%. 2 cases after year 3, no bacteremia. So you can see one of the reasons that we're having problems with pacemakers is infection. especially with the leads and all that. You can see the rates are quite low with the subcutaneous, and it has served one of the reasons that you are moving. One of the reasons that you're moving to other modalities is simply to prevent those complications associated with transvenous modality. Lead failure, 0.1% at 5 years, that's quite low. Mortality, 5.5% at 1 year and 21.7% at 5 years. 5 related to implant procedure, 0 related to the system itself. Then they came the untouched, which use generation 2 or 3 of the subcutaneous ICD devices therapy for rates more than 250. And you can see one was to look at demographics, the age 55 plus or minus 12, 25% were women. There was good representation of blacks, and ischemic cause, 53% of them had ischemic cardiomyopathy. The ejection fraction was around 26 plus or minus 6%. And quite a number of them had comorbidities like high blood pressure and diabetes and kidney disease. And quite a number of them were on good medication. And this time now, there's a bit of dual zone programming so that we can reduce inappropriate shocks, because inappropriate shocks from the previous one, which is around 17%, is quite high. So by doing those dual zone programming, there was a reduction, 54% relative reduction of oversensing and 74% relative reduction of supraventricular tachycardias. In the untouched trial, inappropriate shock was quite low. If one was to look, was 95, less than 5%. And let's move on that. If one was to look at appropriate therapy and survival, first shock success rate was 92.2, final shock success rate was 98.4%. And 1 out of 64 final shock failed but converted spontaneously. Mortality, the VT storm, 7 subjects experienced 58 episodes in 9 storm events, and final conversion rate for all the storm events was 100%. Mortality overall survival rate was 94.9, and there were 53 deaths. Out of those 53 deaths, only 3 were related to arrhythmia, and the majority had various causes, both cardiac and non-cardiac. Then there was the Praetorian, which was a larger trial, more than 18 years with class 1 or 2A indication for ICD therapy, and the exclusion criteria indication for pacing. Of course, the subcutaneous, what they lack is pacing capabilities. And so median follow-up was 48 months, and it had 39 European and US centers in total. And primary endpoint of device-related complication, appropriate shocks, you can see in the transvenous vis-a-vis the subcutaneous, there were less complications in the subcutaneous ICD compared to the transvenous, which had reached statistical significance of 0.01%. Device-related complications, no difference, statistical difference, and inappropriate shocks were more on the subcutaneous, but no statistical difference. Lead-related complications, very minimal in the subcutaneous at 1.4% and 6.6% for the transvenous. Other complication, device-related complications, you can see they're quite minimal in the 31, which represent 5.9%, and 40, I cannot see that, and 40-something percent in the. So basically, there were less complications in a summary in the subcutaneous ICD compared to the transvenous ICD. Now, if one was to look at total number of shocks, there's no statistical difference. As you see, we don't have much ATP in the subcutaneous ICD, while the transvenous, we have the capability of using ATP as one of the ways to overcome tachyarrhythmias. But there was high amount of shock in the subcutaneous, because the transvenous sometimes utilize the ATP algorithm. Now, one was to look at meta-analysis of different studies that have, on the left side, you can see subcutaneous, and on the right side, you can see transvenous. And definitely, if one was to look, the graph on the left is representing a gradual decrease in appropriate shocks from 13.1% from 2013. The studies that were done there, but if you look at the untouched, it's only 2.4%, while in the transvenous, it has remained more or less from 6% to almost remain constant at around 4 to 5%. So definitely inappropriate shocks. Annual rate for subcutaneous were much better compared to the transvenous. Now, as I said, the subcutaneous were lacking the pacing capabilities. So there's extra vascular ICD. It offers opportunity for lower defibrillation threshold, smaller device size, and greater longevity. It also has capability of pacing for assisted pacing support and ATP in a single device. There is a video. I wish I could upload the video, but I couldn't. There is a video to see how it is sort of implanted, and it's quite straightforward. And you can see the device. It is sort of snake-shaped, and that is to reduce the defibrillation threshold. And it is placed just beneath the sternum, and then it is tunneled to the axilla, below the axilla, where we have the device attached to the lead. So the pivotal study, EV-ICD, was a prospective, single-arm, non-randomized, involving 46 sites in 17 countries from Australia, Middle East, Europe, and most of it North America. And the enrollment was 2019 to 2021. So the defibrillation efficacy at implantation, you can see at 30 joules, at less than 30 joules was 98.7%. And freedom from major system or procedure-related complications, quite acceptable, less than 5%. And one was to look at complications, a number of events from hospitalizations, and both procedure-related, system-related, and system and procedure-related. You can see they're quite minimal compared, if you look at them. You're looking at hospitalization of around 7, and most of them could be because of infection to implantation sites, but very few because of the system related. And final results of the pivotal study show that the ATP therapy and shock therapy, 9.2%, 5.8%, 5.9%. What are the complications of the AV-ICD? There were leg fractures, and this was quite embarrassing to some extent because there were 3 leg fractures after 6 months, and all fractures occurred at the same location with the same fracture mechanics. So the manufacturing companies are looking at ways to enhance these defaults and to correct them. And we are very much sure that the next devices will be devoid of this problem. And appropriate therapy at 3 years was almost 16%. That's still not, that's quite high. And as I said earlier, the issue of oversensing and the malpotential noises is what now the companies to work on to come with algorithm to prevent oversensing of either P waves and T waves or any noise that is around the implantation site. So that's all for ICD. Now, ICD therapy in heart failure, it is indicated for patients at risk of sudden cardiac death. However, most implanted ICDs do not treat the accompanying heart failure. You have to use your DMT, and some of them, around 15%, are CRT eligible. But now what happens to the 85%? So there is a modality called cardiac contractility mortality that has offered an opportunity, or has given an option to those people who have narrow QRS or people who don't qualify for CRT therapy, and yet they're either in class 3 heart failure, ejection fraction has not improved. So these type of patients are the real candidates for CCM therapy. So basically, it gives the signals at the refractory phase of the cardiac cycle, and it sort of gives pulses 5 times a day, okay, lasting probably one hour. And there are 2 leads that are connected to the septum, and they stimulate or they sort of activate the cardiac cycle at the refractory period. And this has been shown, and I'm sure all of us are aware, there are quite a number of trials that have looked at CCM, and it's gaining popularity and gaining recognition as one of the modalities of heart failure, especially for those patients who do not qualify for CRT. So now the equation is changing. We have to, CCM is really being implanted in the US. It has really been accepted. It has really been improved. It has really been sort of recognized. Now the question, CCM has no potential for ICD, and our patients quite a number of times commonly might require both treatment modalities. Now you have to place a gadget on one side and another gadget on that side. Really, we don't want that. And if one was to upgrade this, another problem coming in. The other modalities that might come in that might just have to be squeezed within the same cardiac chambers with the same vessels. So we need to come up with ways to minimize multiple devices to be implanted. We can have one device that can serve multiple purposes. And that's, I think, is the way to go. So the CCMD, which has both CCM functionality as well as the defibrillator functionality. And in this way, we can just approach it from the left and then put one device and the leads, when you're defibrillating, the leads, the CCM function is deactivated, and any one time, and it's a rechargeable lead, a rechargeable battery, and there is sort of separation in the CCM function and ICD so that they don't interfere with each other. We need the CCM function, and sporadically we might need the ICD function in case we need to sort of defibrillate or providing ATP. So there was the Integra-D trial, primary efficacy objective, device efficacy in converting induced VF at implant in 100 consecutive patients, safety assessment 1 month, procedural complication, and invasive intervention, major medical intervention, or anything that may lead to death. So basically, 100 patients were involved in the trial, and they look at patients who have stage D, C, and D heart failure on GDMT and left ventricular ejection fraction less than 40%. Patients indicated for de novo ICD without CRT. So, okay, so I think basically, if one was to look at the Integra-D, the VF induction was quite successful in 100 of the patients, and only 2 had to have rescue, but then they are subjected again to the same protocol, and with the reposition of the DF4 lead. And the results were quite impressive. 100% of the subjects had successful defibrillator efficacy test. And the first shock was successful in 94 out of 100, and the remaining 6, they cardioverted with the higher 36 joules. Complication rates, 5, which is quite low. Lead-related was around 1. Pocket infection, again, 1. And this is quite low, and this is quite impressive. So the results of CCM, no inappropriate CCM during ventricular arrhythmias, no events of CCM leading to inappropriate ICD oversensing. 89% of subjects were receiving recommended therapeutic CCM dose at 30 days, and 91% of subjects were 100% compliant with charging protocol at 30 days. The summary successfully performs ICD functions and delivers appropriate CCM therapy. No inappropriate CCM ICD interaction occurred despite hybridized circuits. Our receptor lead positioning demonstrated reliable defibrillation efficacy. No unexpected device complications, and CCMD provides an integrated therapy for the heart failure with reduced ejection function patient, offering both symptom relief and prevention of sudden cardiac death. So my final thoughts, ICDs are fundamental for prevention of sudden cardiac death. Transvenous ICDs were the standard approach for more than 20 years. Subcutaneous ICD has excellent safety and efficacy for patients without the need for pacing. With contemporary subcutaneous ICD devices, the complication rate is lower. There's high efficacy and low rate of inappropriate shocks. Extravascular ICD is effective in treating spontaneous episodes of VTVF. Shocks were avoided in nearly half of all spontaneous episodes due to ATP availability. Incidence of major system and procedure-related complication is low in patients with extravascular ICD through the 18 months. Thank you very much.
That was fantastic. Thank you so much, And thank you, Safaricom, for keeping us connected. Fantastic. Is there any, so we have an esteemed panel here, and we'd love to hear your inputs as well. Dr. Adafe, I know that we've done a number of ICDs together. We'd love to hear more about your thoughts. Hear from Dr. Swale, as well as Dr. Stephen. We'd love to hear from you as well.
Maybe Helen is sorry.
Dr. AJ, Dr. Swale, that is a very wonderful presentation. Excellent. And we learned so much from the presentation. There are a number of therapies that are being offered here, especially the CCM and also the subacute ICD that are not available in Nigeria. I was chatting with AJ via the Port Harcourt Cardiovascular Conference that we need to get someone probably to come and pro us on the CCM and also the subacute. I think the reason why we don't do the subacute here is because of the cost, but very excellent presentation. If you are talking about 2025 ICD, I think you have said everything that is the standard that needed to be said. The only thing that I will say on the perspective of the sub-Saharan African content is that, your population has advanced in knowledge and culture compared to where we dwell in. And if you want to put an ICD for a patient here in 2025, 2026, the first thing you will tell that patient is that you will not stop your medications. That is, the guideline-directed medication must not be stopped, because some of our patients here have this belief that once the ICD comes in, oh God, there is no need for any medication. And after weeks and months, the patient returns back to you worse than where it is. So the problem we have here is also the problem of culture, where some people believe that when you put a device, you are going to reincarnate, and that device will come back with you, and they don't want it. So these are some of the issues we still deal with in the African content when it comes to 2025, 2026. Then also the ones that will not accept it, for the ones that will accept it, you have to properly educate them because majority of our patient here, even though ischemic disease is still rising, because where you are, ischemic disease is the predominant form of etiology of heart failure. But when you come to the Nigerian content or the West African content, the predominant form of heart failure is non-ischemic cardiomyopathy that comes from either hypertensive cardiomyopathy or comes from dilated cardiomyopathy or valvular heart disease or whatever. So sometimes also the mechanisms of sudden cardiac death in this patient also vary when you get to our own environment here. Yeah, there are people that die from ventricular fibrillation, from ventricular tachycardia, and the rest of them, but a quite number of them also come down with asystolia. And if a patient who is in advanced heart failure comes down into asystolia, sudden asystolia, the ICD will not do anything. So it is when the patient has the therapy that ICD is programmed for that that patient comes benefit from the issue of the ICD. Then almost all the trials that were done in ICD, I could remember any one of them that came from the sub-Saharan Africa. Yes, we extract all this therapy to our side, but when you get here, you have to be dealing with a lot of bridges like educating the patient, the communities, the societal beliefs, and the rest in order to get your way through when you plant it. It's a very wonderful presentation. I've learned so much from it. Thank you for so much. AJ.
Perfect. Thank you so much for your feedback there, Dr. Dafe. And Dr. Stephen, did you have any thoughts on the presentation? Anything about what was covered here?
Yes, thank you so much, AJ. I think Dr. Swale, thank you so much. In our setting, the subcutaneous ICDs have not really taken. I don't know what Dr. Swale, your thoughts would be the place of extravascular ICDs in Africa, given the extra availability of ATP. And if you, apart from the difficulty, which would be easy to overcome over time in implanting these extravascular ICDs, they have more promise than subcutaneous ICDs. We never really had a good uptake of subcutaneous ICDs. Do you think we'll have a better uptake of extravascular ICDs? Because if you look at the indications for ICDs in our setting, what number of our patients would benefit from extravascular ICDs, and we could implant less and less transvenous ICDs. In fact, we could just leave them for the people who require long-term pacing or require additional CRT therapy. I don't know what your thought would be on that.
I mean, I totally agree with you, Dr. Stephen. As I said, more than 80% of the treatment is actually ATP, okay, in the ICDs and all that. So one of the dilemmas of the subcutaneous is simply that it cannot offer pacing modalities. It cannot offer ATP. It cannot be used for asystole. So ideally, I think I'm seeing a bit of scope in the extravascular because it's really replacing the transvenous in both ways, both pacing parts and the defibrillating part or the cardioverting part. But the issue of cost has been discussed. But I can tell you, we've seen a lot of changes in the last 5 years, and it's a matter of discussion. I mean, if you look at the Kenya system with the national insurance, the SHA system, the social healthcare insurance, they do cover for ICD. Actually, they give quite substantial amount of ICD. If you apply for CRTD, they'll give you almost Kenya shillings 1.2 million, which probably is almost 8,000 to 9,000 US dollars. They reimburse it for that. So I think if we keep on doing things, or as the the economy of numbers improve, companies, discussion through the companies whether they can give us if they can give us substantial prices for those devices, I think I can see a bit of potential for the extravascular ICD technology picking up. As for the subcutaneous, it's still a very good therapy, and you can see the complication rates are much lower. And over the years, they've been coming lower and lower because the machines are improved, and they're much even lower than transvenous. It's a matter of time, I think, for people to adapt, and unless people like us, we start now implementing these things, we can see how this technology, we used to talk of the same in PCIs, talk of the same in CRT, but now CRT is being put left and right everywhere, even in the government hospitals. So I think sometimes the limitation is our own thinking and our own initiative.
Let me take you back a little bit. Sorry, can I?
Yes.
May I?
Yes, Dr. Stephen, sorry, please.
Yeah, I was going to ask Dr. Swale and maybe Dr. Dafe as well. So the Western world increasingly is looking for further risk certification to implant ICDs in patients with non-ischemic cardiomyopathy. So they're doing these cardiac MRIs and all that. We tend to shy away in Africa from implanting ICDs in patients who don't have ischemic heart disease. And that more or less is in keeping with what the rest of the world is doing. But as practicing clinicians, sometimes you hear of the death of a patient that you kind of know for sure is from sudden cardiac death from arrhythmia. And I kind of wonder, Dr. Swale, in your practice, and in all our practices in Africa, is there a place for just more stringent risk stratification for these patients with non-ischemic cardiomyopathies, or would you just use the current guidelines and implant ICDs in these patients with non-ischemic cardiomyopathy, because they form a big number in our patient population? I don't know. How do you approach the guidelines? Do you usually just strictly give ICDs to people with ischemic heart disease when they meet the criteria? Or do you still follow the guidelines and give with an ischemic cardiomyopathy despite the Danish trial and the reluctance to give ICDs in those population?
I think one of my slides was looking at future directions. And one of the things that we are looking at is use incorporation of cardiac MRI for risk stratification. And no, this is not only for ICD. This is also gaining popularity. You remember the withdrawal trials, the TRADE-HF trials. When can we stop heart failure medication when patients have fully recovered the EF? There was recurrence in quite a number of patients. The question is, yes, there was recurrence in quite a number of patients, but there are also others who did not have recurrence of heart failure once the drugs have been stopped. So the question is, how do we pick those? And one of the modalities that one can use is the cardiac MRI. And Aga Khan, I mean, at least you have, I use a lot of the cardiac MRI in Aga Khan. Unfortunately, in Mombasa, we don't have the software for it. And most of my patients have to travel all the way to just get a cardiac MRI to be done. But I've seen the benefit of that. Patients who I could not classify them, they came up to us having cardiac amyloidosis. One recently I put an ICD, it was simply ARVC. There was a bit of dilatation in the RV, but that was it. But the patient had syncope. And apart from that, the Holter did not pick any VTVF. Now I was able to expose loop recorder, which is, to me, was just waste of time. And this guy was lucky because he had two syncopal attacks. But when we did the cardiac MRI, it confirmed our ARVC. And we had to put a dual chamber ICD. Now, I follow the guidelines. But as I say in my slide, the way I look at it, and then you see those future trials that are designed, they're not just looking at issues of secondary and primary prevention, especially primary prevention. We are missing patients that probably will have benefited from ICD. And the only way is now to see how can we expand the risk stratification. So cardiac MRI is one of them, and genetic testing. There are patients who have the LAM genetic mutation. Those are very prone to sort of arrhythmias, especially disastrous VTVF. So genetic testing and cardiac MRI might extend and sort of re-stratify some of those patients. And of course, artificial intelligence now, by looking at the ECG, might be able to pick those type of patients. If algorithms are developed, might be able to pick type of patients who might benefit from ICD in primary prevention. Maybe one thing I wanted to ask AJ and the panel there, I did not touch much of the life vest. Maybe somebody from the panel can, to make the discussion complete, can give a brief comment on life vest, wearable life vest.
Or Dr. Dafe, Dr. Stephen, do you have any experience with life vests at all in your practices?
Yeah, AJ, yeah, I've experienced when I was training in India, I've experienced the issue of the wearable cardiac defibrillator. Where we used it was for a patient that we were preparing for an ICD. So patient was still in the ward, there was a delay. So we have to put it for some days while that delay was going on. Then the patient was, I think that was in Apollo Hospital, Sarita Vihar. We were waiting for the cardiac MRI results and other results so that we can finally take the patient to the cath lab. So the patient wears it and he was in a ward. I think that was where I did experience that. And why just waiting for the definitive therapy? But in Nigeria here, we don't, or the West African sub-region, I don't have knowledge of any part of it that where we have this therapy offer. It's not an expensive therapy. I think just as Dr. Swiley said, is we need to think ahead and make these things happen. It's not that it's something that is so much that cannot be get around here. For example, it's the same reason why we have not gone into the subcutaneous ICD, because when you mention it, oh, the price is very high. Insurance doesn't cover most of this. Even in Kenya, I think insurance cover, as I can understand here, insurance cover these devices to a very large extent, if not all. But in Nigeria, you don't have any insurance that cover these devices. You pay out of your pocket. So it's still, that is why these therapies are not properly enhanced in our environment.
Fantastic. Yeah, I think sorry, Dr. Stephen, you had some thoughts on LifeVest?
No, not much. Just that occasionally you get a patient that would be a perfect fit for the LifeVest. But I would say overall, in our population, maybe we could invest on more ICDs, transvenous ICDs, and when we can the whatever the extravascular ones before, we invest much on the LifeVest. But yeah, I remember just recently had a patient that would have been a perfect candidate, had an MI, and while we opened up the vessel, then came, had a lot of VTs in that period, went home. When they came back, after 48 hours, they're still having VTs. So ideally should be considered for, in that case now, a long-term ICD, but they could not afford the cost at the time. A candidate like that, while you're waiting to be able to implant, then you could potentially put a LifeVest. But I think in a general population, maybe I don't know Dr. Swale or Dr. Daffy, whether it really makes sense to have that before we implant all the people that requires ICD in our population, and they're quite a number.
I think that's really that's a good point. Unfortunately, it's a bridge in a lot of these situations to implants, but obviously it's not widely available across Africa. And when I found in the US, I worked in a number of cities, and I find that it really depends on how successful the device rep is in selling those. That depends on the adoption of the LifeVest. There's some debates about efficacy of it. But more of the debate is compliance, right? Because it's not an easy thing to wear for a patient. So it is not quite as simple as having those long-term implantable devices that often they forget about until they get shocked by them. So I just had some thoughts, if you don't mind. One of the things you had talked about was, the inability to provide pacing, and with SICDs. And I will tell you that, in the future, while there is the ability with the EV-ICD to provide ATP, it doesn't have actual pacing as a pacemaker solution. It's only that anti-tachycardial pacing. However, the companies are working on integrating leadless devices with SICDs, which means you could have a system that essentially relies on no leads at all in the heart, having a self-contained pacemaker inside the heart, having an ICD with coil external of the heart, which relieves a lot of those issues we do see with infection that we're facing, or with lead extractions down the road due to occlusions. ICD leads are very difficult to extract because the coil can have more adhesion to tissue. So anything that we can do to avoid putting more leads in the heart is ideal. Obviously, that's quite a ways down the road for for a lot of the African settings, but many countries, I think, will start to adopt them. Dr. Jalen just put in one of the first leadless devices in sub-Saharan Africa just a couple of weeks back, by a team that's not coming from external, but implanted, domestically, which I think is fantastic. And we are seeing a number of our SICDs being reprocessed and implanted through some of our friends in the UK are reprocessing the devices, and they're being implanted in Syria by the Syrian American Medical Society. So, in some of in your countries that will allow reprocessed devices, those are other options as well to help defer the cost for patients who couldn't afford these more expensive devices is to simply purchase the lead in the implantation kit and then get a previously loved ICD that will work for a while. And for these younger patients especially, it can be really impactful to have to not give them leads early in life, but instead give them an SICD. So I think those are options to keep on the table. They may not be an option for you right now, but it's coming down the pike. I think the last thing I wanted to mention, I think you really, Dr. Swale, I really appreciate you highlighting, the changes in how we actually program these devices as well. Obviously, companies have come up with more advanced algorithms, but also we can be more thoughtful with our programming. For the longest time, I think a lot of people would do like a 171 beats a minute monitor zone 200 VF, and that was the standard for a lot of our primary prevention ICDs or ICDs where we don't have previously documented high ventricular rates. But HRS in 2019 came out with a set of guidelines for every manufacturing company, and it kind of guides you through how they would recommend programming devices based on the primary prevention, based on different information. And I can just show you, if Dr. Swale is able to stop sharing, I can show you the title of it so you're able to look it up later, because I think it would be very helpful in your review. Thank you so much, sir. Let me pull this up. So I do recommend checking out this paper. It's very helpful. There might be a more recent one. I haven't heard about it, but it goes over Abbott, Bio, Boston, Medtronic, and Microport. And I will typically use this as a good guide to help reduce the risk of inappropriate shocks by raising the intervals to detect, creating more zones for detecting SVT and appropriately withholding shocks based on SVT detection, and then trying to give patients as much opportunity as they can to break out of these rhythms themselves, as well as using ATP as a solution for these implanted devices. So I urge you to check that out as well. But that was all I really had. I think it was a fantastic talk. Were there any final thoughts from our esteemed panel, or Dr. Swale? If you have anything else for us, we'd love to hear it.
I just wonder, AJ, when the subcutaneous ICDs and the extravascular ICDs indeed can do pacing, just that the pacing is uncomfortable and cannot be used long term. I kind of wonder if you have a patient who requires long term pacing, would you then rather just put a transvenous system in place, and indeed they may require CRT as their disease progresses. I mean, if pacing is your main, because indeed this can pace, just that they can't pace for long because of they have that uncomfortable sensation. But once they redesign them and they can pace for long, would you then rather just put a transvenous system in place and maybe with the option of synchronizing the heart?
Yeah, I think that, and if I understand you correctly, you're saying if there's a pacing indication, is an SICD appropriate? Was that what you were?
Yes. So yeah, that's what I'm alluding to. In that case, probably you should just rather than put a transvenous pacemaker ICD that can pace long term, and maybe consider CRT part of it as well.
Exactly. Yeah. So I'm or left bundle depending. I'm not a physician, so I don't get to make those clinical decisions. So I'll defer to you on that one. But I think that's a really good point. Is you don't just put SICDs in because it's the new fancy thing. We have a traditional system that has worked for many years for a good reason, and you don't just have to put in the new fancy EV ICD if we have it. If you still have to add a pacemaker, then it might be a little counterintuitive, but I'll defer to you physicians on making those calls. I don't have to make those, luckily. Anything else, Dr. Dafe, Dr. Swale? Do you have anything else for us?
Yeah, AJ, very good presentation, a wonderful presentation. Regarding the reprocessed ICD, they are also implanted in Nigeria, and I am one of those who have been implanted that, and also during various missions that I had both in Port Harcourt, Abuja, we have implanted them, and the patients are doing very great with them. We have not seen any difference between the new and the reprocessed ICD. The only difference is that the new ICD, the patient can pay, while the reprocessed, the patient don't have fund for it. That is the difference. and following them up, they all has been doing fine. I think that is a very point to make up in our environment. The reason being that most of the device you get in Nigeria, the patient pay out of pocket. I was, during the discussion, the Medtronic rep just forwarded a chat to me that, oh, you see, the ICDs are more expensive in Kenya. I replied him, yes, Kenya has a coverage, insurance coverage. We don't have an insurance coverage in Nigeria. So the patient, most of them pay out of their pocket. So that is why you have a chunk of patients that cannot afford this. And when that happens, then you cannot balance it up with this reprocessed ICD so that you can mock up a large number of patients in the society for this coverage. So it's a wonderful presentation. Then we will also appreciate that we learn more about the subacute ICD, which is not be done here, and also the CCM therapy, which is also vital to us here. Thank you very much, AJ, and all the panelists and the audience.
Fantastic. Yeah, I completely agree. Dr. Swale, I didn't expect you to speak on CCM, so I thought that was really cool to see that come up. I think that's new technology, and we're very excited, for Dr. Fania to join us at STEMI. And if folks are excited to hear about it, we'll ask her to maybe do a little bit of a talk as well on that. So thank you, everyone, for joining us this evening. Next week, we'll be talking about lead extraction, which is very poignant because, as Dr. Swale points out, we're putting these devices in. We have to know how to take them out. And I do want to shamelessly plug that we will be having a full leadless extraction day at Africa STEMI on Saturday, a full session for folks. We were looking for a few core representatives from major regions to come and learn with some of the best extractors from around the world coming together. Dr. Neil Grubb, Dr. Fania Mela, Joe Macaro. We have Moses Wananu, Parag Patel, and many others who are very primary extractors, in their regions that can come in and we can learn from that. So we're very excited for that to happen, and we're going to have a taste of that next week. So please, if you are interested, mark the dates there. We'd love for you to stick around all day on Saturday for us. It is the last day, the 9th, and I think we are going to learn a lot from them. And then once again, thank you to our esteemed panel, Dr. Stephen, Dr. Adafe, and of course, Dr. Swale. That was a fantastic presentation. We'd love to hear your final thoughts if you have any for us. If Safaricom will allow.
Yes, AJ. I think to me, I don't know what your thoughts are with what Stephen was asking. Are you looking at the future trials? First of all, GDMT has really reduced the incidence of sudden cardiac death. So to produce benefits from primary ICDs, probably we might have to look of other ways to extend our indications. But others, if you have to go by what the guidelines and the previous trials approach, we might not be able to see a lot of new things coming in for ICD indication.
Dr. Stephen, would you like to clarify? If not, I think...
I don't know. He had answered before when I was asking about the non-ischemic indications. Dr. Swale, I know after as a working group on sudden cardiac death in Africa, it's been there for the last 5 years. It'll be interesting to see what they find because cost may not be the greatest impediment to ICD plantation in Africa. I think like in Kenya, there are hospitals in Kenya where you can get an ICD planted at share rebate and you don't need to pay anything extra. So cost may not be the greatest impediment. It would be nice to just see what is which patient do you have. So maybe we can check with Jelan and the others about the AFRA, the working group on sudden cardiac death. What's the actual cause? What are the actual causes of sudden cardiac death in Africa or in Kenya?
Yeah, I think that's something we can definitely have a discussion. We definitely should look into more. So I appreciate this back and forth here, and we're excited to hear more about it. We did have one question from the group. How can we do CPR in a patient with ICD? at the sternum, as we've seen. Will the ICD cause any harm in the process? I don't know if the panel has any input on this. I'm not as familiar with the EV-ICD. Obviously, you have to do CPR if CPR is needed. You don't want to be withholding CPR because the patient may have a device that could interfere. So ultimately, I think that would be the plan. I know with a lot of devices, placing a magnet over the device, if it's inappropriately trying to shock, will withhold therapy. And I assume that is the same with the EV-ICDs. So for some reason, you're causing some sort of break in the lead during your CPR or something along those lines, I assume this would help to inhibit it. Maybe from the panel, do you have any experience at all? I wish I could answer more clearly, but I would say do the CPR, and if it starts shocking inappropriately, put a magnet over the device. Anyone have any thoughts on that?
Well, I think the way to approach it, because I've had several cases of a patient who had ICD and requires CPR. The first thing is, what is the reading that is giving that patient the cardiac arrest? If that reading is a shockable reading, then AJ, what you said applies. You can continue the CPR, then get, and if the shocking is still persistent, one of the things you try to do is once you get the defibrillator, you put the pad, then either you put a magnet over the device, then you put your manual defibrillator, continue your CPR, and you take over the shocking with the manual defibrillator. I've had series of patients on this who are on ventricular tachycardia or ventricular fibrillation, and they had a lot of shock at home before they got to the hospital. And as they got to the hospital, we put the monitor on the patient, and immediately we noticed that it is ventricular fibrillation or ventricular tachycardia. So what we do, just the patient has gotten to you, you need to put a magnet over the device so that you can also reserve the remaining capacity of that battery. If not, if you allow the battery to shock continually, that battery will run down. So that can preserve for another day. So with that, you take over the activity with your defibrillator is on, monitor is on, defibrillator is on, then put a magnet over it. And if you don't have a magnet, what I tell my resident, if you don't have a magnet and the patient gets to you and you have identified the reading, the first thing you do, put the defibrillator, and you know you are going to take over the shocking activity of this patient, then switch off the therapy of that patient while the patient is still with you. And that period, that patient is constantly on that defibrillator, so that you assign a nurse to that patient and the monitor is perpetually on, so that the patient is being defibrillated while in the hospital. That works perfectly. And with that, you don't have any problem. So you can do your CPR, do your shock without having any problem. But if the reading that give the cardiogenic shock is not a shockable reading, that is where the issue comes from. If it is not a shockable reading, let's say it is asystole or pulseless electrical activity that is giving it, one thing that you should know is that defibrillator will not give a shock. So if it will not give a shock, you don't have any problem. So follow the therapy for asystole or pulseless electrical activity and continue while your defibrillator is still by the side, because these things do change. While you are in the ICU or in the hospital setting, a patient who was having pulseless electrical activity can change over to a VT or the rest, and the device will start taking over. So these are the ways to do it, which we do here, and also to preserve the lifespan of that battery, because while the patient is with you in the hospital, you have the manual defibrillator with you there, and you are allowing the the device to keep shocking. That device will run down, the battery will run down, and you need to replace that battery. In an environment where the battery is expensive to get it replaced, so once the patient gets to you, the battery has kept the patient alive till he gets to you, so you just have to deactivate it or put a magnet over it and take over with your defibrillator if it is a shockable reading. If it's not a shockable reading, follow the other therapy and get the patient out of that place. AJ?
That's perfect. I think that's really good. Oh, sorry.
I was just wondering, just in case, because they mentioned in specific the extravascular, maybe they were thinking about the position of the lead, the retrosternal space. And I'm not sure, to be interesting to see what the registry shows, like when you're doing the resuscitation, would you like damage the lead or would you, like damage the lead? Yeah, that would be. But to see that the subcutaneous ICD is actually on top of the sternum as well, and that concern has not been there. Because that's what they were asking about, being that they were asking specifically about the extravascular ICDs.
Well,
I'm wondering if it's more protected, with the EV-ICD versus the SICD being substernal. You'll probably get some degree of protection, but I would certainly interrogate the device once you're done with CPR, and look to see, if you're seeing noise in the lead as a result of fractures due to CPR. But obviously, you have to prioritize CPR over everything. You need to perfuse the brain. The longer you go, the worse it's going to be for the patient. So CPR first, and then deal with the rest, when we have the chance to catch our breath.
I agree with you.
I think so. We're 21 minutes past the hour. I think we could probably talk about this all night, and I'd love to, but I'm sure everyone else wants to get back to their families. So I appreciate everyone, once again for joining us from the entire Africa STEMI team from Heart and Life. Thank you for our esteemed panel, Dr. Emmanuel Adafe, Dr. Stephen, and of course, Dr. Aswali. Thank you very much for that impressive and fantastic conversation. We look forward to seeing you all next week to talk about lead extraction. We look forward to seeing you in person at Africa STEMI. Everyone, enjoy the rest of your evening.